Welcome to this afternoon's discussion on the M. Night Shyamalan film Split. So, to our group, where would we like to start? You could also formulate this as a series of questions too. That's certainly in play. There's no wrong answer.
I think the obvious choice would be Kevin.
Kevin? All right. Observations on Kevin Crumb.
In the film, he was said to have DID, so I guess we'll just say DID. And there were 23 alters present, though I think we only saw 5 or 6 of them, all seemingly presenting with different personalities and even maybe some different co-occurring mental disorders as well.
I think it's very fair that dissociative identity disorder, or DID, can appear on a shelf exam. So before we continue the discussion and focus on this condition in one of the main, if not the main character, Kevin, somebody define for me what DID is. Previously known as multiple personality disorder, DID is a dissociative disorder characterized by an individual's sense of awareness and consciousness being taken over by a distinct personality state. Right? Those states, those altered states of consciousness, could last for minutes to days. The longer they last, the higher the risk of the individual also experiencing and manifesting dissociative amnesia. What is dissociative amnesia?
They will have like gaps in their memory. They might end up like in different places where and like have no reoccurrence in between, like what happened in between.
Right. So it's exactly right. Dissociative amnesia is defined by gaps in memory that is beyond what would be considered, quote, normal forgetfulness, end quote. That's per the American Psychiatric Association. Like any mental disorder, what is chief in the differential? What is one of the initial steps a clinician must take to verify or confirm dissociative amnesia? That those gaps in memory are not due to an underlying medical condition and or the effects of a substance. Not that anybody here would have done this, but as an undergraduate, if you've drank too much and you woke up the next morning with a gap in memory, you do not have dissociative amnesia. Right? You have a blackout. So, and that would be the direct and physiologic effects of a substance, and therefore not a mental disorder. And then, of course, another condition that often comes up both in film as well as shelf exams are gaps in memory that are the result of traumatic brain injury or other medical conditions. I think TBI with unconsciousness is going to be high in your differential there. Is there any evidence that Kevin Crumb either abuses a substance that would explain his altered state and or have a medical condition? Not really, right? So right now we have M. Night Shyamalan complying pretty strictly to the DSM in terms of building this as a fictional, if not sensational, case of dissociative disorder. Any questions about any the dialogue, any of the case formulation up to this point? All right. In addition to DID, and that is dissociative disorder due to an underlying medical condition or the effects of a substance, there are 2 other conditions to consider in terms of this chapter in the DSM titled The Dissociative Disorders. What are the other 2 dissociative disorders published in the DSM-5?
Is one of them like depersonalization?
Good. Yep. So what is depersonalization, derealization disorder? And I'm going to start you off because I don't want you to answer this and put me on the spot. This condition, this disorder, is defined through episodes of recurrent depersonalization and/or derealization that are clinically significant. Right, so in either case, we're going to call it depersonalization, derealization disorder. Of course, the next question is going to be, well, then what is depersonalization? What is derealization? So who wants to give it a try?
I think isn't derealization, people kind of feel that they're out of their own body, like they're
Depersonalization.
oh, that's depersonalization.
Mhm.
Like
So then, and that's true, meaning that anybody who's ever had an out-of-body experience has a mental disorder. Right, you're smiling at me, so the answer is no, but you're being
Yeah.
too polite. You don't want to call me on that, right?
Yeah.
But you've been right. Why? Why not?
because that could also, like we talked about, be caused by, like, for example, substance use.
Could be, yeah. Let's say that for a particular case it has not. Then you're mentally all right. Why not?
When it's recurrent.
Yeah. It has to be recurring, and it's got to cause clinically significant distress or impairment in functioning. Only when it meets that criteria or those criteria could we call it a disorder, in this case, a depersonalization, derealization disorder. If that is depersonalization, what is derealization?
The constant feeling of deja vu.
Yeah, so it's deja vu is probably the easiest example of when an individual experiences their immediate environment as unreal in some way. So depersonalization focuses on the individual, and then derealization on other, which would be the immediate environment. Deja vu being an easy example, meaning that anybody who's ever experienced anybody here not experienced deja vu? You guys are not on camera, so feel free to raise your hand. Anybody here not experienced deja vu? So everybody here has a mental illness. Right? Why not?
Because it's not recurring and it's not causing any clinical impairment.
We got that, right? Everybody's got that. And I beat that dead horse down enough where you're not going to miss this on the shelf exam, right? Cool. All right. So with regard to depersonalization, derealization disorder, I don't know why. I honestly don't know why the APA continues to call it dissociative amnesia and not dissociative amnestic disorder, because they'd be consistent in doing so. And then DID. Those are the three conditions. Two more major teaching points to either of these conditions. Number one, in each case, the individual's reality testing remains intact. If not, if there's a breach in reality, if what they're saying, what they believe is not embedded in reality, then what becomes higher in the differential diagnosis?
Dissociative psychosis?
Psychosis.
Yeah.
Yeah. So then you're flipping chapters, and you have to work up a psychotic disorder. Is that the case here?
No.
Yeah, I mean, when he's an alter, whether we call them Kevin, Patricia, Hedwig, they seem to be reality-based. They know, they would tell you the time, the date. It seems like they're probably reality. Now, if they were telling you they were getting messages from aliens, then it's complicated. What also would be complicated, and I don't know if M. Night's listening to us, but also an awesome plot to a fictional movie would be one of those characters, maybe Patricia, would get messages from aliens, but when Patricia switches to Dennis, they're the reality base. So one of the alters is psychotic while the others are not. But I've never seen that. And I certainly have not seen that in clinical practice, nor have I seen that in fiction, in film.
So is it not possible?
It's very unlikely.
Is it possible that one of the alters has maybe ADHD or BPD, but the other one doesn't?
It's possible, yeah. And there is medical evidence, albeit individual case reports, where their physiologic markers change with alters.
So how does that affect in your brain? Because you said right brain takes with left brain, so a particular part of it would have, and the others don't?
Clearly, we don't understand that. Oh, we're live. You're good. I'll come right out. We don't understand. It is so rare. First of all, the point prevalence, and this is one you will be tested on, of schizophrenia is between 0.5% and 1% of the U.S. population. DID is even less frequent, with a lower incidence than that. So there's zero chance we're going to be able to truly study this with a scientific method. So we could only rely on individualized case reports. So very difficult to answer direct questions with any real answers or scientific answers. So I don't know. Other thoughts here? Other aspects of Kevin that you found interesting?
Kind of bouncing off the previous point of like co-occurring disorders, it seems like Dennis might have had some sort of OCPD presentation. Yeah, specifically because of how he was, using, I believe, that yellow cloth to touch things and make sure things were at a certain angle and tidiness and such with the bathroom.
So somebody define for me, using big words and acronyms, somebody define for me what OCPD is.
It's a personality disorder that's related to OCD, where you have you're really fixated on perfectionism, making everything correct, like the moving things around as he was doing. I
Yep.
don't remember which cluster it is, but
Right.
one of those.
C. Right, you had everything right. If you guessed the letter, I'm sure you would have gotten it. So it's a cluster C personality disorder that is exactly characterized by what you said. This is the perfectionist, the type A personality. Right. So if it's easier for you to remember on the shelf exam that it's the type A personality, please remember it as such. I think it's probably a nice, at least clinical pearl to remind yourself that the word obsession and the word compulsion are nowhere found in the definition. So even though it is related to OCD, it is not defined through obsessions or compulsions. The exact opposite is true of OCD, the anxiety disorder. Right?
And Dennis is the only one who has this.
Yeah. Yeah. To answer your question. Yeah. Since we're discussing the cluster C personality disorders, what are the other two conditions published in this cluster, in this group? The group is defined as a cluster only because it shares similar characteristics. So hence we call it a cluster instead of a group, but it's a group of three. What are the other two? Avoidant personality, right? Which is fairly straightforward. People avoid other people, other places, things like thoughts and feelings. Avoidant personality, and then there's one more. Dependent personality disorder. So the individual with dependent personality needs to be reassured of their every next step, and they have a very difficult time with the autonomy provided them. They always need to be reassured. Unlike obsessive-compulsive personality, both dependent and avoidant do tend to improve with age. Right? They do tend to improve with age. There are two other conditions, personality disorders, that tend to improve with age. Both are from cluster B. What are they? Any guesses?
Borderline personality disorder?
Yeah, borderline. There is some evidence in the medical literature that they have more stable relationships in their 40s and 50s. Sometimes, I'm not going to even mention because I think it's a little stigmatizing to say, but yes, improve with age. And then the other one is antisocial personality.
Antisocial?
Yeah. Those are the four. If asked, small tangent, what is the mode of psychotherapy that is found to have empirical evidence in improving the outcomes for people with borderline personality disorder?
DBT?
Yeah. Dialectical behavioral therapy is your single best answer there. Right? And it comes up on exams a lot. Back to Kevin. Any further thoughts about him? So, characters other than Kevin Crumb in M. Night Shyamalan's split of interest.
The doctor.
Dr. Fletcher? What about Dr. Fletcher?
She doesn't have the ethics. She's not following.
Yeah, she's not the most ethically practicing of physicians. That's for sure. Makes a lot of mistakes, significant boundary issues, and unfortunately for her, I think for each of those boundaries end up in her demise. So we could definitely go, and I don't think it's necessary for shelf purposes, but we could definitely go off on a tangent and talk about ethics in medicine. You guys have classes for that, though. So. But surely I think Dr. Fletcher might be your poster child for that. And there's probably more to say about this offline to further kind of support that idea. So I think it's another major character with another major mental
girl?
disorder. Huh?
The girl?
I don't know. I'm not sure there's much there.
The uncle?
Hmm?
The uncle?
Yeah. So what's going on with the uncle? What's his name? I forget his name. Yeah. Perfectly normal? No. What do we got? Yeah, yeah, pedophilic disorder, right? So, deriving sexual gratification in relationship with a prepubescent child, in this case, his own niece, right? So that's pedophilic disorder. Pedophilia or pedophilic disorder is one of the sexual deviancies or paraphilias published in the DSM-5. There are three categories of sexual disorders, one being the paraphilias. What are the other two, neither of which are demonstrated in this movie?
With the dead, or like obsession with like the dead. I forget what it's called.
Necrophilia?
Necrophilia.
That's also a paraphilia,
Okay.
even though it's not one of the top 9. Therefore, only the more common ones actually have names or labels. That would be like a paraphilia, not otherwise specified, or I'm not sure the current, like other/specified. There's current terminology, but it's basically in a grab bag category. Yeah. Other than those paraphilias or sexual deviancies, though, what are the other two categories of sexual disorders? No.
Arousal?
Yes. So the sexual dysfunctions, right? So here in prepping for your shelf exam, your favorite board review text, and then open up a visual Google Images of the sexual response cycle, because they all link to the different stages of the sexual response cycle. So it's much easier to study and then remember for yourself. And then the final category would be gender dysphoria. Right, that's an illness that is in a category of its own under the sexual disorder. So gender dysphoria, the sexual deviancies, the paraphilias, and then the sexual dysfunctions. Right. This movie portrays a sexual deviancy. It's a paraphilia, and that single best answer would be pedophilia or pedophilic disorder. Differentiate for me the philia from the philic disorder. And unfortunately, pedophilia is probably the worst example here, but
Would philia mean like it kind of causes distress in their life? That they have
the opposite. Yeah.
Philic is that it causes distress in their life, and then the other one is that they're okay with it, they
Enjoy it.
Yeah, I mean, in each case, they're going to enjoy it. The philia is the behavior,
Okay.
which is aberrant, meaning that it deviates from a culturally sanctioned norm. That's all it is. And therefore would never or should never come under the evaluation of a psychiatrist. When that behavior, when any behavior, one that deviates from a culturally sanctioned norm or not, results in clinically significant distress or impairment, we're allowed to now put the word disorder after it. So the paraphilic disorder differentiates from the paraphilia. The paraphilia is the behavior. The other one is the behavior that causes clinically significant distress / impairment in functioning, and therefore we're allowed to actually call it a disorder. Right. Again, because it is a crime, all of them are crimes, most of them, with the exception of pedophilia, is a misdemeanor. But you should know the differentiation, both clinically and for shelf purposes, of the behavior versus the actual disorder. And the 2013 publication of the DSM-5 readily identified those two as separate. Previous, if you were deviant, you were disordered. Other observations, M. Night Shyamalan's Split. We have about 8 minutes left.
Question? I'm assuming the answer is probably no, but there was a comment about 2 alters coming to life at the same time, and therefore we're able to write simultaneously, but different words. Is there any scientific evidence?
No scientific. Again, probably yes, because this is so rare and behavior is so not following the textbook. That said, no scientific evidence as to explain that would explain that. Yeah. The other thing I wanted to make sure that we covered, getting back to the dissociative disorders, is making sure again, especially for shelf purposes, you get the single best answer. Somebody with a pre-existing history, a past psychiatric history significant for DID presents to you. And they present with clinically significant episodes of depersonalization and derealization over the past week. And there's no evidence of drug use. And after a comprehensive physical examination by the primary care physician and neurologist, there is no underlying condition that would explain the new symptoms. Single best answer: depersonalization, derealization disorder, dissociative amnesia, DID.
DID.
Yeah, it's DID, right? The idea here is that DID incorporates both amnesia and aspects of depersonalization and derealization. It's all wrapped up into one, so DID takes precedent. If the individual does not have established DID, or upon your evaluation you do not believe that they have DID, then dissociative amnesia takes precedent. Dissociative amnesia incorporates aspects of depersonalization and derealization. So that's just something to keep in mind as well. When an individual presents to you and you are providing an evaluation for a dissociative disorder, you have to respect that hierarchy as well as the role of a psychotic disorder, right? So ask yourself, does reality testing remain intact? If no, you're now looking at a psychotic disorder. If yes, you have to think DID until proven otherwise, and then dissociative amnesia until proven otherwise, and then only then depersonalization, derealization disorder. That would not be due to the effects of a substance or an underlying medical condition. Right? That's the algorithm that you should work, that formulation.
What are some good questions to ask for reality testing? Like, what exactly does that entail?
It starts off with positive symptoms, so definitely delusions, fixed beliefs that are not reality-based, and then perceptual disturbances such as hallucinations, auditory being the most common.
Okay.
That's where the conversation starts. It's part of your routine.
Yeah.
H&P for psychiatry, your basic psych assessment.
Yeah, because I've heard the term like reality testing, but I didn't know exactly what the real definition is.
Yeah, I mean, I would just default to the positive symptoms of schizophrenia. Beyond hallucinations and delusions, you could go to disorganized behavior. That includes catatonia, and even disorganized communication or speech.
Okay.
You said drug use does not affect it, but what about like the hallucinogens, the
Doesn't affect what?
associatives? Would that cause DID? Having
Yeah.
taken
Oh, yeah. I mean, for any dissociative disorder, including DID, you're going to have to assess the potential effects of a substance, and there are 5 known classes of drugs that can induce dissociation and psychosis. If they induce one, they can induce the other. So whether we're talking about a substance-induced psychotic disorder or what was previously known as a substance-induced dissociative disorder, they're one and the same neurobiologically. So those are 5 substances, and we reviewed them just yesterday. What are they?
mica,
What do you got? Methamphetamine and other stimulants.
Inhalant.
Good.
Cannabis, alcohol, and then
Hallucinogens. That's it, right? And the other thing to remember is that anything alcohol can induce, with one rare exception, the benzodiazepines and sedatives can induce too. So that's all wrapped up in one. But otherwise, there's the 5. As you heard, the acronym is MICAH, MICAH, and that's the main character. That's the main male character in Paranormal Activity, yet another movie, albeit not assigned, about DID. We could end it here. Any final questions or any final thoughts? We're good? All right. I think we'll see everybody back next week.